Today we're going to be discussing eye movement desensitization and reprocessing, also known as EMDR. This is a technique that has its theoretical basis in the adaptive information processing model, which was developed by Francine Shapiro. My name is Dawn Irons, and I'm the Clinical Director of Hope Harbor Counseling, and we will be journeying through this topic together. Francine Shapiro was the founder of the EMDR therapy. She first stumbled upon the beginning concepts of EMDR in 1987 when she noticed that spontaneous eye movements had a desensitizing effect on disturbing thoughts and memories. In the beginning, the idea was called EMD, and it was only through research and development that Shapiro came to understand that an integral part was missing beyond the desensitization, which was the ability for the brain to reprocess a memory. The early literature on EMDR was very mixed. It was discovered that many of the early studies, the samples were too small, or an improper dosage of the treatment was given. There were also many studies that were done by people who had never had official training in EMDR. And when you have an untrained clinician offering services and doing a study over a service they've not been trained in, kind of leaves the results questionable. But by 1995, the first clear definitive study showed that the safety and efficacy of EMDR and the process was no longer considered to be experimental. There are many current proponents of EMDR, but due to time and space, we're only going to discuss just a few here at this slide. Dr. Daniel Amen, he is the founder of the Amen Clinics. He is double board certified psychiatrist and a neuroscientist. He was the pioneer that began using SPECT scans to show brain changes with many interventions and counseling. EMDR has studies showing before and after brain changes, but there's also many other interventions that Daniel Amen has been shown through the SPECT scans to be making a big difference. The U.S. Department of Defense and Veteran Affairs has adopted EMDR as one of only two treatments that they recommend at all. EMDR and exposure therapy are the only two therapies that the Department of Defense and Veteran Affairs recommends for soldiers with PTSD. There's also global international support for EMDR, and I'll go into that much more extensively when we get into the multicultural section. EMDR is a therapeutic approach guided by the AIP model. AIP stands for Adaptive Information Processing. The AIP model teaches the existence of an information processing system that assimilates new experiences into already existing memory networks. These memory networks are the basis of perception, attitudes, and behaviors. Perceptions of current situations are automatically linked with associated memory networks. In the adaptive information processing model, pathology arises when traumatic memories are not processed properly and become frozen in time and are unable to connect with other neural networks that have adaptive information. When a memory is stored in its distressed state, it can be easily triggered, causing emotional, cognitive, and behavioral reactions. This is my personal analogy of the brain. It's the ultimate file system. During new client orientation, I tell clients that the brain is like the ultimate filing system. There's a file for every human experience. The brain forgets nothing, even if we cannot consciously remember. The only exception is that the brain has no file for trauma. When trauma occurs, it's as if the gears in our brain get stuck. They keep trying to process, but they get nowhere because it's stuck. This is where the symptoms begin to become problematic. The eye movements activate the part of the brain that begins to process, and the gears begin to move again. The desensitization of the traumatic events to the point where they can be filed into the brain. When the brain is able to reprocess a memory that was once stuck, we begin to see process. Often the client tells me they can feel a physical release of the tension, and then the somatic symptoms cease. Some unique features about the AIP model is that it allows for pathogenic memories to be activated and have access to adaptive neural networks. This model is the basis for what the 8 phases of EMDR are built upon. We'll briefly go through the 8 phases of EMDR. Phase 1 is the comprehensive patient history and treatment planning. Phase 2 is preparation. This is where I give a general orientation of EMDR, begin to build the rapport with the client, and we go through the safe place exercise. This is a relaxation exercise that helps the client to self-regulate when anxieties begin to rise. Phase 3 is the assessment phase. This is where I have the clients make a top 10 list of their most critical traumatic memories that they have. And this is also where we identify the positive and negative cognitions that they have about themselves related to those traumatic memories. In phase 4 is the desensitization. This is actually where we begin the eye movements. I will do a set of eye movements with the clients, and after about 4 sets, we do what we call an SUD scaling. That is the subjective units of disturbance. So on that scale of 1 to 10, 10 being the most anxiety ever and 1 being no disturbance at all, I'll have the client scale where they are. Typically what we'll see is that as we begin a traumatic memory, the number can be, a 7, an 8, sometimes higher. But as we begin to do the memory, or as we begin to do the eye movements, we see that desensitization start to happen and that number starts to decrease. Moving into phase 5 is the installation. This is where we begin to positively reinforce the positive cognitions. And as we do those eye movement sets, as we reinforce that positive cognition, same concept, we kind of stop after every 4 sets of eye movements and we scale the VOC. The VOC is the validity of the cognition. In phase 6, the clients, I have them do a body scan. This is close your eyes, just do a body scan from the top of your head to the bottom of your feet. Is there anywhere that you're holding tension in your body? So we assess for that residual tension. And typically after an EMDR is fully processed, clients report that their body has a resonance of just release of tension. As we go into phase 7, this is the closure. This is where we return the client to that state of homeostasis, and this happens regardless of whether we were able to complete the full processing of that memory in 1 session. Oftentimes it can take 2 or more sessions to complete a specific target memory, but at the end of every session, it's important that you bring that client back to that place of homeostasis. So for me, when I see that I'm running out of time in the session and I know that we're not going to complete, I tell the client, we're going to stop here today. And at that point, I take them back to, so let's go back into the safe place exercise. Let's bring down these anxieties. And so I return the client to a more homeostasis. In phase 8, this is the reevaluation process. This is where you check in at the beginning of the next session and you're reviewing symptoms, the target image, to see, do we need to continue processing on this topic, or are we ready to go on to the next target image? The goal of EMDR is to cognitively process pathogenic memories or traumatic events, as evidenced by a decreased emotional reactivity in response to triggers. That's the desensitization, followed by a positive cognitive restructuring. And this happens in the installation phase. Techniques for EMDR are in giving the bilateral stimulation, and that can happen in several ways. The typical way is the eye movements. Now that can be done with the therapist's fingers, or there are technological advances, there's light bars. The tapping, it's still a bilateral stimulation, but usually you can hold these electrodes and they offer electrical pulses alternating into each hand. So you're developing that bilateral stimulation, but it's through the tapping. Another way of offering the bilateral stimulation is through audio stimulation. And this is much like when you go get a hearing test and you have to put those headphones on. And the audiologist puts a tone in one ear and then the other. So in the same way, if somebody cannot track the eye movements, you have the other options with the tapping or the audio stimulation sounds, but all of them together still offer that bilateral stimulation. In the next slide, you're going to see a brief video that shows some of the alternative technologies that can go and work with the EMDR.
EMDR therapy can be quite exhausting for you as a therapist. The EMDR kit is a piece of equipment for therapists that makes EMDR therapy far more convenient. It allows you to adapt to the needs of your clients with visual, oral, and tactile stimulation, which can all be used individually or simultaneously. All parts of the EMDR kit are wireless and can be controlled via the EMDR kit app that you can install on your tablet or smartphone. Convenience, adjustability, and no more physical discomfort. For more information, visit our website www.emdrkit.com.
The role of the therapist is to facilitate healing. Research shows that the most valued aspects of the therapist's role, according to clients, include the therapist's personality and the rapport that is built with the client, an ability to empower clients, flexibility, intuition, and a sense of ease and comfort in working with trauma, and a commitment to the small measures of caring that clients identify as helping them feel better.
If you have experienced something horrible and have developed psychological symptoms such as flashbacks, fears, sadness, or sleep problems, you may well be helped by EMDR, a proven and effective therapy. Suppose you have been confronted with a violent crime, an accident, you have been bitten by a dog, or you have had to deal with sexual abuse or violence at home. Such a powerful experience is stored into your brain with a lot of emotions. Once such a memory is stored in your long-term memory, it can bother you for quite a long time. The disturbing memory keeps coming back unintentionally, for example with feelings of powerlessness or believing you are not worthwhile. EMDR therapy can help you get rid of these complaints and feelings. At first, an EMDR therapist will ask you to activate the memory of this disturbing experience from your long-term memory. The memory is now stored in your short-term memory, also called the working memory. Then the EMDR therapist will ask you to focus on this horrible event. From there, the therapist will move his fingers in front of your eyes rapidly back and forth and ask you to track his fingers as best and as fast as you can. By keeping a traumatic memory in your mind and tracking the fingers of the therapist at the same time, the working memory gets to process a lot of information at the same time. As it is so much information, the image becomes blurred and loses its emotional charge. When the emotional charge of an image lessens, it also becomes easier to think differently about the experience. You will notice this because you feel less powerless or you feel worthwhile again. The intrusions have gone and you feel less anxious. You feel less depressed, you sleep better, and because you have managed to leave the experience behind you, you start enjoying life and looking forward to the future.
The case study of Mallory. This is a case from my actual private practice, but the name has been changed to protect confidentiality. Mallory was a 28-year-old white female who came to therapy for trauma-related issues. She describes that her father, her brother, and her 12-year-old niece all commit suicide within 3 months of each other, and she had found 2 of their bodies. The deaths had occurred 3 years prior, but Mallory had persistent nightmares daily for the last 3 years. She reports severe insomnia, social anxiety, and panic attacks. She sought me out for EMDR therapy. Mallory could barely tell the story without severe hyperventilation and crying. The shock was still evident, and it was as real as if she had found the bodies yesterday. After 4 EMDR sessions, Mallory reported that the nightmares had gone away completely. After 7 sessions, Mallory had resolved the issues to the point where she could discuss the trauma as a matter-of-fact event, and it did not have the traumatizing emotional response that she had had when she first came in. Mallory was able to re-engage in social activities, and the panic attacks had ceased. At a 6-week follow-up session, Mallory reports that the symptoms never returned, and at that point, we terminated services. I'm going to share with you 3 therapeutic activities that we often do in EMDR. I've already discussed the safe place exercise. I do this during the preparation phase. This exercise teaches self-regulation of anxiety and disturbing memories. The float forward technique enables a client to envision doing a task that they cannot see themselves doing. It's the mental version of acting as if. The butterfly hug. This technique is a relaxation exercise that clients can do anywhere when the anxiety starts to rise. It's a do-it-yourself version of bilateral stimulation, which can stimulate similar calming effects found with EMDR. At the end of the slideshow, you will find a demonstration video of the butterfly hug. When we begin to look at the multicultural appeal in the empirical research, there were plenty, but I wanted to put these specifically to show that there is just a global appeal working with EMDR. Here, as I've highlighted in red, you'll see the American Psychiatric Association, Jerusalem, Israel, the National Council for Mental Health, practice guidelines for the International Society of Traumatic Stress Studies. In France, the National Institute of Health and Medical Research, Northern Ireland Department of Health, the Dutch National Steering Committee on Mental Health, Stockholm, Sweden, the Council for Medical Program Committee, United Kingdom Department of Health, and the United States Department of Veteran Affairs and Department of Defense. So there is global community recognition that EMDR is an effective technique. Some of the limitations regarding EMDR is that it is a relatively new process. It was founded in 1987. The early research was very conflicted, but more stringent and replicable literature began to emerge in 1995. Over the past 25 years, longitudinal studies have proven favorable. But in comparison to Freud, Jung, and Adler, EMDR is still in its infancy stages. Practical implications for EMDR is that it is empirically backed by research. It tends to be a short-term therapy that can run between 6 and 12 sessions. and clients report almost immediate results. So, to summarize some of the more important facts about EMDR, it is a highly recognized and respected therapy internationally and has a large multicultural appeal in its ability to treat trauma. EMDR is one of only 2 therapies recommended by the United States Department of Veteran Affairs and the Department of Defense in treating soldiers with PTSD. EMDR has a high efficacy rate that is backed by empirical research and verified internationally.